move on to the next theme, which is Open Health Disrupting Health Policies? Bernard Accoyer, Catherine Desroches, Claude Evin, Olivier Véran, and the debate will be moderated by Elisabeth Hubert.
Voilà, très bien.
On mélange? On mélange.
On mélange.
Je mets note.
Moi, j'ai pas de notes.
J'ai des notes, mais...
Chacun a ses anti-sèches.
We all have our little notes here. So it is a difficult task ahead of us now because we're going to conclude SHAM 2015, which I think has fully met its expectations and its theme, open health from the virtual to the real, virtual to reality. This roundtable will be a difficult one because I think you're all aware that politicians have been criticized since the very beginning yesterday of our debates. They've been referred to often, but in a more negative light than to be congratulated. So we don't want you to just have to defend yourselves and justify yourselves. That's not the point of this roundtable. Many things have been said, but I think we need to shed a different light on politicians' role during this roundtable. And based on what we can perhaps identify as a certain number of failures or regrets for things that were not done properly, we should draw some lessons to make sure that these things do not reoccur. So we have about 45 minutes, and I think that could be the first point that we could focus on, is some of the failures of the past. And secondly, I think we should look at how politicians can play a role. We saw this full well. This can be from a legal standpoint, a regulatory standpoint, financing as well, but also as an operator. What is your point of view on this topic? And the third aspect that we can then conclude on, which is the one that should preoccupy us the most, which is at the heart of this roundtable, which is open health. Is it really revolutionizing, or will it revolutionize healthcare policies? So to perhaps evacuate the first unpleasant subject, which was the perception of politicians' errors in the past, what could have been done differently that was not done? Claude Evin, you're the one with the highest position and the longest seniority. Well, I think it's important after the exchanges that we've had since yesterday morning. Many things were expressed. I think we need to perhaps try and make sense of some of the events that were debated yesterday. Now, perhaps indirectly, I'm answering your question, Elisabeth. What was not well done? Well, it's always easy with hindsight when you look back to say that, yes, we probably missed a few boats with the electronic medical record, but other countries didn't succeed either from the very first attempt. So let's look toward the future. And if we can really foresee the future, I think it's less open health that will be revolutionizing healthcare policies. It's more that these healthcare policies are being revolutionized by a certain number of challenges, which really challenge and call into question all of the stakeholders. And to respond to all of these challenges, yes, we heard a lot of people criticizing, and Laurent Alexandre had a real criticism this morning. And I think we need to move away from the virtual back to reality. Nevertheless, yes, this is a huge global challenge, and the local and territorial reality, I think there are territories, for example, where there's no access to the internet in France still. So we see that there's a real gap in some of these areas. So what is our system having to deal with? There are a certain number of challenges which are imposed on the professionals and the stakeholders, whether or not they're even dealing with open health. I think there are 5. There's an economic challenge, we know that, and it's becoming accentuating. We have also an epidemiological challenge, which is the explosion of these chronic diseases. 13 million people have the five main chronic diseases, and also there's an aging of the patients. We need more coordination among the stakeholders. And here's this territorial and ecological ecosystem organizational problem. How can we respond to a problem of an insufficient number of healthcare professionals? How do we organize things in the territory? And then there's a democratic challenge, access to more information, the patient as an empowered actor in his own health. And then, of course, the technological challenge has impacted our entire system with non-invasive surgery, which has reduced residence times in the hospital. So open health is improving certain services rendered, because I think there are two elements in open health. You're improving the service for professionals and patients, and also, indeed, there's an accumulation of data that we can use to the benefit of the entire system. So this is where I think we'll find meaning and then be able to identify a certain number of proposals for the future. Thank you, Claude, for not having answered my question, but at least having widely opened the debate. Bernard, you have also a lot of experience from the past. How do you perceive, Bernard, the role of the politician? We did see that the politician's role was poorly perceived, not well understood. Politicians have to deal with a certain number of challenges, but if you look at some of the things that haven't been set up in France, a lack of interoperability, there was the failure of the first electronic medical record, but maybe the future will show us that that failure will allow us to succeed better in the future. But how can politicians deal with something in France which revolves around protectionism? The previous roundtable said that sometimes people want to protect the citizens against their own interest, because the citizen is putting out secrets that they want to perceive. So what can you say about the role of the politician in all of this? Well, politicians that I became after having been a medical professional for many years, the politicians have learned that we need to beware of politicians. Now, and that's my profound conviction. And what Claude Evin just said reinforces that conviction. I declare that everything we did for many years in terms of organization and major plans and development of new processes and new technologies was a huge failure. We had a bad national health insurance policy and a bad healthcare policy, not one that encouraged innovation, progress, and innovation. So I dare to say this here this morning, that we, above all, in these new areas which will be completely revolutionizing healthcare and healthcare policies, the risk for France of missing the boat, missing the revolution, or arriving after everyone is huge if we continue to proceed in the same way that we've been proceeding for several decades. So consequently, I believe that the role of the politician, to respond to your question, dear Elizabeth, is that politicians should get the least involved as possible. They should just look at dealing with the ethical rules and the security rules, and that's it. And the rest, we should encourage individual initiative with the stakeholders, with the professionals, with the startups and the companies, with the insurance companies. Mandatory social security is one thing, but complementary health insurance, certainly we need to open up more to these systems. We need to encourage original financing, also tax systems, the way we do in other areas of industry. Since our French Republic has replaced the engineers leading the state with people who graduated from the National Administration School, ENA, we've been multiplying errors. So let's try to avoid these errors in the future. Well, that's a successful comment. But politicians are still the ones who draft the laws. I didn't exclude that, but I said yes, for security and for ethics, politicians must be involved, but they should stop there. So that would be a very light law then, in your opinion. Now let me turn to two legislators who have been involved in the new health modernization law in France. Olivier, how do you react when you hear this light position that Bernard prefers for politicians? And then we will talk to the senator after that, Catherine. Well, I share this observation that politicians are extremely absent from the fundamental debates opening up. I'm only 35 years old, and I feel like I'm part of the gerontocracy that Laurent was referring to. 8 years ago, I was part of the conference on the organization of the French health system, and we all agreed on a diagnosis, but we realized that we don't know whether the wall is very distant, but we have a real difficulty in setting up the right tools. Now, politicians were absent from these major debates. We heard about the role of GAFAs in the previous roundtables, but this year we saw the arrival of an artificial heart. There was an artificial uterus. There have been huge medical progress, and I think the politicians have a very hard time facing this. We don't know whether the wall is too far or closer. So 65% in an American study, 65% of the schools, children and school children will have a profession that hasn't even been invented today. So among these jobs, one was a children's designer 15 years from now. So you see these forecasts that are being made that are probably a bit of a fantasy, but they force the public authorities and public powers to decide how we're going to face these new challenges of tomorrow. Faced with these important challenges, we still have to ask ourselves the question to see whether the version 12 of the electronic medical record is going to be a success. We're still asking questions whether we will be able to know whether GPs in a territory are doing 50% or 80% of general medicine if they retire 5 years from now or 15 years from now. I think we need to be very humble with these tools that we have today. Probably the arrival of healthcare data and the capacity to use these healthcare data will allow us to be more active, but we need to be humble, but that doesn't mean the politicians should be absent. I think we should try to anticipate more. We should try to work more in a concerted fashion with the economic and industrial and research stakeholders. We will not be able to succeed without all of these stakeholders, even if we wanted to exclude them. So politicians must stop thinking that they are experts and the wise men and women. We need to call upon more experts in the field when we're writing the laws. And I think we need to take inspiration from what we've done on the electronic medical record to do exactly the opposite from now on. Well, how can we succeed and to ensure that we are not, with the laws that are proposed, voting and drawing these imaginary lines like the ligne Maginot in the Second World War that will be overcome immediately? Well, I agree that our laws are too complex. I agree with Bernard. These laws have dozens and dozens of articles that are almost like incantations. And with this new modernization law, we excluded some articles that were already satisfied with the existing laws. I think we draft laws that are extremely complicated, and they then have application decrees, which mean that they arrive even later in terms of their real implementation. So this is completely behind the times in terms of what the economic and the industrial world is already experiencing. And often they're way ahead of us in terms of the texts that we're writing. We're always behind. We're missing the boat instead of anticipating, taking ownership. It seems like we're running behind the train. And the objective is to try to inject a maximum degree of security and write these laws which, seen from the outside, already appear old-fashioned with respect to these innovation sectors. So, and in the case of open health, that's the case. I think we need to force ourselves to have much more limited legislatory texts, and I think they will be much more effective in that case. Well, in this law, you will see that there are very few things related to the subjects that we've talked about. In this new bill, there's Article 47, which has its qualities and its faults. It will be discussed in our session next week, but there's very little that touches upon everything we've discussed yesterday and today. So they're opening healthcare data and telemedicine will only be effective in the field, as you said, in the Maine-et-Loire area, which is my local département. There are still cities that don't have internet or even cell phone coverage. How can we write texts that will harmonize when we still have such inequalities in France? So we're going to have to make progress on those fronts and then leave some freedom to these stakeholders in these fields. I think we've had some texts in terms of research that were created way too many constraints. We're going to have to assess some of the laws that were already passed a few years ago. Well, I think you are trying to justify a little bit the position of the politicians. So we don't want you to be beating yourselves either. But let's come back to the challenge. Open health is really revolutionizing the healthcare sector. So what is the role of the politician? And when I talk about the politician, not just the legislator, there are people that need to give impetus. This country has had very strong political proactivism in the industrial sector that opened up possibilities that are those that we are familiar with, which are our universe today, and which have built the world as we know it today in France. How can politicians become a facilitator and a proactive stimulator and not an operator? In the past 2 days, we've heard a lot of criticism. But so what can be the genuine role of the politician? And when I talk about the politician, I don't just mean the MPs. I'm also talking about what we call the operational authorities in the field who are really, they can be facilitation tools to respond to the different challenges you mentioned. Well, I've already evoked the fact that politicians must give meaning to all of these challenges. The second element that I wanted to mention is that, indeed, they're not just parliamentarians. I think all of the actors should be feel concerned. You see that we've discussed a certain number of issues since yesterday morning. We had people from industry, the pharmaceutical industry, the insurance sector, but everything that comes to play in the conventional relationship between the National Health Insurance Fund and the healthcare professionals. Let me draw your attention to the fact that it's all of these stakeholders who need to take a new turn. I believe, indeed, that the regional level is a level that will allow us to be able to progressively absorb and make these changes. The challenge that we have to meet is that the capacities for initiative and experimentation that were evoked to organize the system differently, to develop telemedicine that we were talking about this morning, remain still very constrained. And legislators, as Bernard Accoyer said, the legislator should leave some capacity, more capacity for initiative and innovation. When you open these experimentation, and I recognize that this is the ministry that's controlling this, stop asking people to do it based on specifications that come from the minister. If we want real experimentation to take place, we should leave some room for initiative and just give a framework. We were talking about telemedicine this morning. It's in a law on the financing of the French health insurance system that for the first time we've seen experimenting in terms of telemedicine. At the regional health agency around Paris, when I was in charge of the regional health agency, I wanted the hospitals in Paris to invoice telemedicine visits that would have avoided children having to travel to Paris for consultations. But people said to me, but you're not an experimental region. You're not allowed to do that. So I had to finance this with the Regional Intervention Fund, which is a fund that is even being reduced right now. So this is a concrete reality that we have to deal with. So I believe that we must indeed, laws must open up more capacity for experimentation. We need financing for experimentation. We shouldn't allow people to first have to prove something and have a return on investment before we authorize the experiments.
I do recognize that we're in a system in which the funds are limited or restricted. But if we want to move forward and respond to the goals, including in the area that we're concerned with, that's to say, adapt the response in different areas, and that you're at both ends of the chain, then you've got to have the capacity to take initiatives. To broaden the debate, even if you, as you've already said, that the politician's role is a minor one, as a lawmaker, in fact, the previous roundtable struck me for a particular reason. It's because of the particular dimension that the capacity to build algorithms are taking. In France, we're not too bad at that. And certain examples demonstrate that. But the challenge is to build IT algorithms to be able to have a capacity to analyze data that corresponds to the challenge at stake, and do this all within the scope of the rules that apply to our culture. So isn't this a subject where precisely, just like the industrial policy that we've applied over the last few years, in which the politicians should impel things so that we know what to do and don't leave it to other players to develop these algorithms and impose their analysis, which is going to be predictive of the policy that we have to set up, because they're analyses that we won't have done and the tools won't have been set up by us. Well, freedom is rationality, and these are two things that we haven't got in our country. Freedom is something we don't have because we restrict absolutely everything in the area of health, and it's stifling us. And you can see what the results are with the despair that the medical profession is showing today. And I think it's essential to do something about this at this stage, because health data expresses a way of having free access. We're during a period in which scientific truth is constantly being challenged. When you're in the hard sciences, most say things aren't certain. But if we continue doing things like this, France is going to miss the train, which we absolutely mustn't miss. The implementation of the matching all this data, of lumping all this data together, is something that we can do. We've got the mathematicians and the physicists. And have we got somebody to support them? Or, well, in a previous life, I associated the anatomical and physiological and electrophysiological anatomy with the physicists, and I couldn't do that at all today because there are so many constraints. Let me finish what I was going to say. Freedom means getting people closer together, working together, working in networks and making some money, because it's essential to make money too, not just to make a livelihood out of it, but to make people want to succeed. And you'll see that things will go very well. And let's come back to my introduction. Ethics is safety. And then off we go. Here in Haute-Savoie, I live 30 kilometers away from here. We're in a French department that needs health. If you, we need to be able to send X-rays directly to the doctor when they're done at the foot of the ski runs, and we've got to offer mountain medicine another way of funding itself rather than just relying on public funding, and then you'll see that things are going to go much better. Yes, but this is off subject. It didn't really answer the question. Olivier, I think you had something to add. Well, in medicine, you've got to be very careful. I'd like to remind Bernard that 12 years ago, we told patients that you had to lie their babies on their stomachs to avoid infant sudden death. And now we're saying exactly the opposite. The issue that you've raised concerning health data and the capacity to analyze it is something we have to take as it comes. I'll give you 3 examples. There are 3 major challenges. First of all, prevention. Open data and prevention can be very good, and it can also be very bad. Let me explain why. Open data can be used for targeted prevention on risk populations, because otherwise there will be inequalities. If in the future you're capable of analyzing the data, you have a diabetic patient, for example, who spends a lot of time watching TV and drinks a lot of soda, then you can send targeted messages to that patient. And that can be a daunting commercial tool. You can use these messages for an alcohol producer or cigarette firm. So you've got to have a regulatory body. And I'm saying that as a hospital doctor, I get phone calls from people I know or colleagues who saying, where should I go or not go to get my grandma's hip operated on? We have classifications in the Figaro, and we have the TripAdvisor in health, and I think there's probably another way of going about this that's situated somewhere between the two. And I think you've got to respond to the fact that the users want to assess the healthcare they get. It's legitimate. And we heard earlier that if we give ourselves the means of selecting risks, we may go back 20 years, which is what happened in the US. And if you mess up your capital, then it's your own fault. And I don't want that to happen in Europe. Care management is going to be pushed to the extreme, and the users are going to become patients again if you push it to its limits. So we need to play a role as regulators, but for the moment our laws, our legislative tools are rather like the toll fare badges we use on the motorway in August. Just simply one thing. As one point that I'd like to bring up again. Open health is going to change a lot. And if you listen to Bernard, I think in the future we're probably going to have a lighter government and parliamentary assembly that will be far smaller, because at the end of the day, their role is going to be restricted or circumscribed. And what I'd like to say is simply this. On the aspects of political change, when we listen what hope and health could be, and I see the proposals that are being put forward, and here I'd like to turn towards a senator in the department is very close to the one I live in, that's to say a fairly rural and urban area at the same time. When you see the issues related to medical demography and the solutions that are being applied, coercive solutions, our connected methods and telemedicine and other methods we see developing going to be things that the politicians will use to change all this? And aren't the politicians going to suppress a certain number of obsolete administrative tools that no longer to respond to the needs today? And thirdly, experimentation, yes, but when are we going to deploy all this? So give me your vision on the first aspect, Catherine. On the problem of what we call medical deserts, well, I think that we're still at the stage of coercive action. We need more freedom and trust. I think you've got to trust the professionals out there in the field. They're aware of the difficulties that they encounter. And when they go out there into the areas, they will go to the areas where there are no doctors if they have the right tools to use. If you can train multidisciplinary teams and improve telemedicine, even if you do it in different places, if they have the right network, they'll feel that they can work. I'd like to come back to this, because if we don't reduce the digital rift, then a lot of people are not going to be able to do these new jobs. And there are also patients who won't have the same type of relationship with the doctor. There won't be a doctor available 24 hours a day, 7 days a week. There'll be one doctor on Monday and another on Tuesday. So I don't think there are going to be that many problems. It's just that we've got to have somebody there permanently on call and tell people we are going to have to go and set up your consultation here or there. I think trust is the key word. It's the future of our country that is, in fact, going to collapse if we don't install that fundamental concept. So trust rather than coercive methods. This debate on medical demography is anachronic for me. We're in a European environment. There's free circulation of healthcare professionals. You've got 4,500 doctors who've been trained in Eastern Europe who can come along and set up business. The whole thing is to know how to adapt our system and how the tools that we've been talking about for the last 2 days can be used in France. Open health is a tool. There are challenges to rise to. The theme of our debate is open health. Is that something that's going to be an upheaval in health policy? Health policy means that we have things that need to be built up. In the previous debate, we talked about prevention, but we've also talked about epidemiology. What are precisely the different areas that open health is going to enable a government and a health minister to act on and to do? And I'm not talking about setting up another think tank to use open health. I'm talking about really developing action, which is something that is going to concretize our health policy. Well, let's come back to the analysis that I made at the beginning. There's no point in doing this in relation to open health. Open health is something that can facilitate it. But why is there no coordination between the different players today? It's that you've got to take a look at. There are several things that today are not allowing this cooperation. It's the allocation of resources, for example. Today, we don't allocate resources for private practitioners that enables us to do this globally. Everybody is in their own little compartment. So you can set up open health. But why have we seen failures? Well, it's because you need to change the way you organize things. The tool is there to give you a way of finding the response and changing behaviors. And if we don't do that, we'll still have these medical deserts. It's an illusion to envisage using coercive action. It won't work. It would be better to try and find out how you can get Madame Durand in the provinces or at Provins. How can you answer Madame Durand at Provins? She's got a name. She's in a place. She's got a disorder that's probably a problem. She's probably got social issues to deal with too. And she's in an environment in which there is no healthcare professional today. So we've got to find the right answer for her. It's not just an issue of open health. It's how we can actually mobilize professionals and get them to create a network so that they can actually find the right answer for Mrs. Durand. And it's the answers that are going to facilitate things. But let's first work on the issue so that we have legal text so that we can do this. Let's work with the professional TSN, the numeric care network is a good approach to start with. There are 5 regions that have been identified by the Investment Commission nationally for these 5 territories. And in the 5 regions, we've got the work that has been done in certain areas with the professionals to put numerical, digital technology, make digital technology available. But we mustn't fall into the trap which you mentioned earlier. We need a national specification for it because we are going to have to take into account the healthcare professionals and the hospitals to deploy it in a region. So these are some down-to-earth answers we don't actually need legal texts for. I totally agree with what was said earlier, but we're not living in a nice cuddly teddy bear country. And recently we also said that we've got too many legal texts that doesn't enable us to take initiatives out there. Let me give you 2 examples based on the analysis of open health as a tool. First of all, for years, we've had PMCI data that is very interesting, and we can use it for some very interesting analyses. The challenge now is to relocate the hospitalization. Why don't we use it to reach that goal today, using the data from the PMSI, and why don't we draw lessons from it to change the way we organize things? This would enable us to develop health policy as broadly as possible. On this level, we do use the data. Olivier mentioned earlier the issue of diabetes. In the Ile-de-France, we've identified some areas where diabetes type 2 was particularly prevalent. And what we find is that there are a certain number of very interesting elements in terms of prevalence. And once you've identified the area concerned, and you can do that, I've identified areas in which I could carry out our prevention policies. You certainly need more targeted data, but we can build something with that. And the regional health boards are starting to do that. But with the professionals out there in the field, how are we going to be able to find solutions to enable the professionals out there to act differently when they're faced with specific situations that are different from others in the region? That's where we need the capacity to adapt that we haven't got today. I mentioned an example earlier, and you bounced back on another. Olivier, yesterday at dinner, we were talking about hospitalization. How in the future, because you have responsibilities to take, are we going to make these data that come from tools that we've got today that produce big data and give us a capacity to analyze it? How can we go from the data, from the analysis we make of it, to the scale of decision making? How can we, to use another example, Google enables us to predict epidemics. And what are we going to be able to draw from this information to put our own tools in order? Are these tools going to be a support for us? And are we going to be able to draw a line under the existing organizations that are changed by these new tools? Olivier, Bernard, Catherine.
We have left-hand and right-hand governance that is very conservative, and it's the same for e-health, which is a Pandora's box. Financiers think that e-health includes 60 million consumers, so it's a Pandora's box. So I'm worried. As Laurent Alexandre was saying, what we're not doing today, other people are doing instead of us. What we don't think is useful today, well, maybe we'll have to buy that kind of thing from people in the future. I would apply to legislators my own principle. We must not harm innovation. When I see that in a parliamentary debate, 10 years were necessary to authorize research on embryo stem cells, when I say that a reporter on television asked me to provide an article about innovation technologies and that there was a cost efficiency from a medical point of view, whereas the innovation law was created in 2008 and it hasn't been used. So how often are we going to use it? So there is a technostructural problem, and I'm not being populist. We can move things, we can change things, and I think political powers can do this. We mustn't drag down innovation, and we need to think ethically about all of this. Earlier on, I was talking about the child designer. We've talked about transhumanism. I wonder, what is the end purpose of all of this? Where are we going? What framework are we giving to research? Let's define an ultimate goal, a framework, and let's free up energies so that we can do things properly. So the question that you're asking is, how do we use health data? We use the health data to provide better care, and it's up to the stakeholders involved to do that. I don't think we are using the data. I don't think we're using hospital assessments. Otherwise, there wouldn't be too many tens of thousands of extra beds. This is what I was trying to say. So was it different in Saint-Nazaire? When we are serving the state, we mustn't lie down in front of a mayor who says that and say that such and such a unit should not be closed. So this may be what is going to happen in 20 years. This brings me to assessment. In reality, health data are going to lead, I hope, public powers to finally follow objective results of hospital, clinic, prevention, practice, protocol assessments. And at the end of the day, hopefully we'll be able to go beyond political protestations. So that is what we need to do. We need to leave room for reasoning based on objective data, because health data are the only things that should be used to decide to open or close protocols or clinics or hospitals. That's the starting point. We need to reverse the paradigm. In other words, the big campaign that says, okay, I'm not closing such and such a site. I'm not going down that path. Well, let's do what is best for progress, for health. This is what should be guiding us. And that freedom, it's something that we find at the heart of everything. We've forgotten it. We do need some political action, though. We've got a little less than 2 minutes left. I don't know if we've brought up all of the subjects, that we've gone through everything, but all four of you, you're involved in political action. In the future, if there is political change, you may be ministers. You may be ministers of industry, of the economy, of research, maybe ministers of health. Catherine, you have a measure that you need to take in the future as minister. Based on what we've been talking about in Cham, what measure would you take as a politician, as a minister? Well, I think that I would trust researchers. I think that we've set our sights too far away in relation to events. And I think that what we're moving and we're confusing things. There are conflicts of interest. And so we've got these expert committees who have to be experts on subjects that they're not familiar with. So these are non-expert committees that we've been setting up. That doesn't mean to say that these people do not have their qualities, but they're not necessarily experts on the questions that they have to study. I think that the measure that needs to be taken, it's not something that we're hearing about today, but I think that this measure needs to focus on unblocking innovation and research. Olivier, if you're a minister in the future tomorrow, for example, if you're a minister, what decision will you make? I will not be Minister of Health, that's for sure. He said it, and we all heard him. So clearly the question is, okay, I would look at health democracy, and I would take health professionals by the hand. I'd bring them around the table so that we could talk about the development of the profession. French doctors are not as well paid as their counterparts in many other countries. Practices are not as advanced in France as they are in other countries. We don't have a European dynamics in terms of medical demography and healthcare. So this is what I was saying earlier on. We need to provide new assessment tools for healthcare users, and together we need to build a system that is modern. So we need to change our reference system. Very short. Same question for Bernard. You're a minister. I don't want to be health minister either, so it's going to be hard to find a health minister in the future. Well, I would bring together a certain number of experts, not politicians, but scientists. I would get them to identify all the obstacles, all the barriers to our health system, and I would ask them for guidance so that we can encourage innovation, progress, and open health, in other words, by getting rid of all of the barriers between professionals, institutions, obligatory and additional insurance companies, basing all of that on experimentation and free enterprise. Claude, you're back in the ministry. Yes. I think we need to develop initiatives at regional level, at area level, by bringing together different stakeholders. This is what's been said. We need to have a 360-degree vision, and we need to make sure that these stakeholders can take a certain number of initiatives. Thank you. I hope that what you have said, all of you, your vision that you have shared with us, your political vision, has been heard. So, Guy, would you like to conclude? So, Sham is over. Thank you very much for all of the teams, TV Pro for the production, Loyudis for the simultaneous translation, the Congress Center team who hosted the event. See you next year on Friday, the 30th of September, and Saturday, the 1st of October. The theme has yet to be decided upon. Thank you for being with us.